By the end of this episode, you'll understand the hidden forces behind your paycheck that could be fueling your stress and limiting your freedom to practice medicine on your terms. Welcome back to another episode where I help younger physicians decrease stress and increase income by transitioning from corporate to independent practices, even without any business experience. In this episode, you'll learn and understand the 4 main ways physicians are compensated. You'll discover how hospitals really get paid and learn the first step to building financial freedom through smarter payment choices. So, welcome to another episode of the Independent Physician's Blueprint, where we help physicians to decrease their stress and generate wealth in this crazy world we're living in. So, today we're going to be talking about billing for patient care 101 and how physicians get paid after residency. Now, I did some recaps of previous episodes, and in episode 113, I really focused on Medicare Advantage and the money tree and how patients or how physicians who are contracted with Medicare Advantage companies get paid either through the capitation rate or a monthly payment or fee for service, where you render a service, where you see a patient and you get paid. And what I realize is that we need to go back to the basics and explain to physicians how they get paid, how organizations get paid, whether they're employed, if they are starting their own business, if you're starting your own business, whether you're hospital-based versus office-based. It's important to understand how you get paid. And patient care only can happen if the most important person in that tree or in that cycle is paid. And that's you, the physician. The healthcare entities cannot make money without you. And you are really the main driver for healthcare revenues. And I think it's important for physicians to understand their importance. And I know that coming out of residency, you may not feel as though you're important, but you are important because without your knowledge, without your care, without your discipline, then you would not be able to, or the organization that you're working for, or you yourself may not and would not be able to generate income. So there are 3 different things we're going to talk about today, and that's fee for service, capitation, hospital reimbursement, and membership-based practices. And we'll try to give the basics of each of these segments of payment systems so that you can understand the importance of each one of them. So if you have an office, or if you have a service that you're rendering, or if you have a storefront, if you have a franchise, you would need to know where your monies are coming from. It makes no sense to open up a store and not know where revenues are going to be coming in, not know what your payment processing systems are going to be, how are you going to collect money, your credit cards that you're going to accept or debit cards that you're going to accept, bank accounts that you're going to use. These are all important things of any business, and healthcare is a business, and this business of seeing patients. And you're the most important aspect in that business. So fee for service, what does it mean? Well, fee for service is a term that describes when you see a patient and you bill for the services for that patient, you get paid by the insurance company. But in order to get paid by that insurance company, you have to have a contract with them. So whether it be Blue Cross Blue Shield, United Healthcare, Anthem, Cigna, all these are Medicare, Medicaid, all these are either government or commercial entities that contract with you as a physician and a hospital to render services or to see patients. So when a patient comes to your office, they pay a copay, they may have a deductible, and you then see the patient, you put a CPT code, a common procedural terminology code that allows you to tell the insurance company what you did for that patient. That patient then So it allows you to tell the insurance company what you did for that patient. If you saw the patient and did an EKG in the office, or if you did an ear lavage, if you did a knee injection, all those codes are related to a payment, and a fee is generated and is sent to the insurance company. That insurance company then verifies that that service was actually rendered by a contracted provider, and then that insurance company sends you a payment, and it could be 10 days, 14 days, 30 days from the time that you see the patient. So that is a fee that you get for a service that you render. And same for surgeons. Surgeons will see a patient, perform a procedure, and get paid for that procedure after they submit the bills. Sounds pretty simple, but it's not, because it involves so many different layers of processes. So from the time that you see the patient to the time that you input the information to the electronic health record, and then you submit it to your billing system, that billing system sends it to a clearinghouse. The clearinghouse then sends it to the insurance company, and then the insurance company verifies the claim, verifies that you're contracted to see that patient, and then cuts your check. So you can imagine there's a lot of processes involved and a lot of things that can happen in between that. The second type of payment system, and we talked about this in season 1, is a capitation. And that's through Medicare Advantage programs. So Medicare Advantage programs that contract with Medicare or Management Services Organizations, or MSOs, they receive payment from the insurance company, the private insurance payers, and they distribute those monies on a capitation basis. So if you have a panel of 100 patients, 500 patients, they pay you X amount of dollars per member per month, and regardless of whether you see the patient or not. And if you do well, and if you have good quality scores, you keep the patients out of the hospital, you don't spend a lot of money on brand name medications, you may receive an additional bonus on top of the capitated payment. And that's usually through the primary care services. As a specialist, it would be usually a fee for service payment. And so that goes back to what we talked about first. So capitation payment is not common, but it is becoming more popular. And patients or physicians who understand the system well, as you know, in the course that I have, you can do very well in Medicare Advantage world. Although reimbursements have come down in 2024, 2025, I think if we, as physicians, manage our patients well, we can make a decent living seeing patients under a capitated model. Although that is changing, and it's not as lucrative as it was in the past, and there's a lot of scrutiny these days. So that's capitation. Third is something I think is important for all you hospitalists out there and all the physicians who are going to work for hospital corporations or be involved in seeing patients in the hospital, whether it be in the ICU, as specialists. It's important to understand how hospitals get reimbursed, because you're not going to be billing the insurance company directly. The hospital is going to bill the insurance company for the services that you're rendering. And they're giving you a salary to perform those services. So you really need to understand how hospitals get paid. And this is something that I have done a lot of study on, and wanted to kind of help our residents and our specialists or fellows coming out understand that the hospitals get reimbursed differently than the outpatient services that are rendered. So hospitals get paid on a DRG system, a diagnosis-related group. And that diagnosis-related group is associated to ICD-10 codes and procedures that are performed in the hospital. So how is that payment calculated? So there is a base rate that is multiplied by the DRG weight that equals a hospital payment. So the base rate is a standardized dollar amount that the CMS Center for Medicare and Medicaid Services assigns to a hospital, and it's based on hospital characteristics. So if you're a teaching hospital, if you're in certain locations, you may get more payments going to that hospital system versus another hospital system in another area. and that is the base rate. But on top of that base rate, there can be additional components that can increase the payment to that hospital. Now, how does that work? Well, if the hospital is spending a lot of money on expansions, or if they're a teaching hospital with a lot of upgrades and a lot of, equipment being purchased for the hospitals, or if there's depreciated assets that are calculated, those hospital payments can be more than if another hospital doesn't have those capital improvements and those things happening. So hospital, I like to think about it as, if you see a hospital expanding and they're getting residency training programs and they are doing lots of things in the community, then you best be sure that those hospitals are getting paid more than a hospital that's not doing those things. So hospitals get money by the DRG. So the sicker the patients, the more procedures that are performed on that patient, the higher the reimbursement to that hospital for that patient. And another thing, we as physicians need to understand, hospitals are in the business of filling beds. I had a podcaster, I think his name was Patrick Bet-Davis, PBD. I heard it on a podcast, and he was saying, how hospitals, how do hotels make money? Well, hotels make money by filling up the beds. So if there's a high occupancy rate in that hospital, in that hotel, that is, then the hotel makes a lot more money. If you have a hospital that has no one admitted to the hospital, no one admitted to it, is that hospital making any money? Absolutely not. So what do hospitals do? They do everything in their powers to have people go to the hospitals. They put up billboards. They say 5-minute waits. They set up ERs in the community. So emergency rooms are being set up all over at least all over the Tampa Bay area. And those hospitals are using those emergency rooms to fill up their beds because that's how they make money. So as a hospital makes money, they need to hire physicians. Physicians are paid a salary. And that salary, let me tell you, physicians that are employed by hospitals typically will help the hospitals generate a lot of money. So I'm going to just leave it at that. You can think about it and understand it better. But just remember, hospitals are like hotels. They have to fill up beds to make money. And lastly, membership model. So you've heard me talk about concierge medicine or direct primary care. And that is a movement that's happening in this country where insurance costs to employees as well as to employers are going up. Every year, insurance costs for the employer goes up. And that is becoming more and more unaffordable for those employers. So what's happening? They're switching these plans to high deductible plans where things are not covered until you meet a deductible of $5,000 or $7,500 or $10,000. So what happens then? Access to care is going down. You're having to spend a lot more money before services can kick in. And so people are looking at direct primary care where you pay a membership fee to see your primary doctor or your primary provider. And this is something that, as you know, in several episodes that we've talked about, is really a big push for primary care doctors these days. So what does it mean to you? So as a physician, if you're not seeing any insured patients and you're only doing direct primary care, you are then really in control of how much you make And it's about marketing yourself. It's about marketing your services. It's about setting fees for your services that are competitive in the market space. And so what happens is, if you have a membership of, let's say, 500 members, and you multiply that by 100, let's say, right? So we say 500 members times 100, and it's a pretty simple math. If each member is paying you $100, and you multiply that $100 or that membership times 12, that's $600,000 that you're making in total revenue. And if you factor in a panel of 500 patients, and you have 22 days in a year, 22 days in a month that you see patients, you're going to be averaging about 8 to 10 patients a day that you're seeing, making over $500,000. Now, if you bump that up to 600, then you can obviously do the math. So you're seeing a lot of growth in the direct primary care space because physicians are realizing that we can do 80% of the things that for our patients without having to use a hospital system. And in a direct primary care model, you can contract with radiology centers, lab providers at lower costs than what you would contract with them with other. Sorry, I can't even speak today. So you can also contract with national lab providers as well as X-ray providers that will charge patients less than what they would charge an insurance company. And, I can tell you so much more about that, but we'll keep it at membership model is something that's really growing rapidly in this country as patients look for alternative ways of getting healthcare. And so we talked about from the complicated to the simple, and the dependence on insurance versus independence on insurance. And, take a look at some of the episodes on direct primary care. I think it's important to understand the benefits and, of course, the risks, because you do have risk, and there is a fairly large outlay of cash that you would need initially to start up a direct primary care practice or membership model, or even a concierge practice. And I think you also have to have the experience in caring for patients. So maybe it's something that can be a hybrid, or as you're growing a direct primary care membership, could you be doing a side gig? Could you be doing a locum tenens? So these are the main 4 ways physicians get paid after residency. Interested in finding out more or asking me a question, we are now able to receive texts from the show notes in your podcast app. So feel free to drop me a text. Tell me what you think, and love to dive deeper into some of these other topics, especially the hospital reimbursement, because I find it fascinating how hospitals get paid, and most of us don't have a clue as to how that happens. So hope you like this episode. If you do, leave me a note, leave me a review, and we'd love to hear what you want to hear in future episodes. Thank you so much for listening to the podcast. If you'd like to hear more, subscribe, follow in your favorite podcast app so you'll never miss an episode.